Okay, we're live.
Well, go ahead. Let's say hi to everybody.
Well, hello.
What's up, everybody? How are you? It's Bill Forster with my lovely co-host, Malika Forster, today. And our other co-host, Dr. Theresa Mack, is in the building. And this is Real Talk Chronicles. We are here today. First and foremost, we want to wish you all a happy holidays, right? There's so much going on in the world, politics, health, just whatever the situations you're dealing with. The bottom line is, you're still here, and that's the beautiful thing about it. I want to give a shout out to the sponsors. We don't have them up here anymore. I have to ask my lovely wife to put them up there again because
you're hardworking wife.
I'm not going to take that away from her. Absolutely. But we got the Daily Arts and Survival magazine. We got Melba's. We got, of course, Soft Illusions, Art Gallery. We got Row House. Got to put them in there. We have Chocolat. So these are all people that I still shout out and still show some love to, with all due respect and things of that magnitude. So let me ask you how you doing before we get to Theresa and other guests tonight.
I'm wonderful. It's good to see you. It's been a while.
Yeah, it's been a while. And for those that don't know, we have two. We became fur parents, so that's what you may hear in the background.
Oh, yes.
So, Theresa, how are you doing?
I'm good. I can't complain. I'm looking forward to the holiday.
Absolutely.
Home, so that would be nice.
You got any special plans?
No, just going to have dinner here, and then they're all going to, do their
get
little
face.
What did you say, Bill?
Tell them get out your face after that.
I got to work. We both have to work on Wednesday, so
wow.
We eat early, and then we just have the day to chill.
Yeah, absolutely.
How about you guys?
I'm not a big holiday person, and Malika, she really does it with her mother. I will say that, right? Is that
well?
I don't want to speak out of turn.
As we get a little older, things change, right? So growing up, my mom hosted for our entire family, and I look back on it and I'm like, wow, she must have been pretty tired. That was a big feat. So now we just kind of take it easy and lay low. So I look at her and have lunch with her, and look at Bill and have dinner with him, and watch some TV and zone out a little bit. So
what is it? Whatever it is, just be thankful for what you're doing. And
it's going to be restful.
Exactly.
Yes.
I think I see James on. Hi.
Yes. Hi. So for those, James. We have Dr. James McKnight is in the building. What's up, brother? How are you?
I'm doing well. How are you two doing?
Oh man, go ahead. He said, "You all." So go ahead. I'll let you.
Yes, we're great, James. It's good to see you.
You too. I'm looking forward to spending some time with you guys through the holidays.
Hopefully.
Absolutely. Yes, exactly. Good. Actually, and before we get off here, I'll ask you guys what does the holidays mean to you? Because this will be the last one we'll do until the new year. Well, no, we have December, right? Yeah, maybe. Yeah,
see how the holidays are going.
Yeah, exactly. Exactly. So, I apologize for those that I sent out a massive text. What is that? I sent out a massive text to. I thought we was going to have the other Mack. I thought we were going to have two Macks for the price of McNutt. You know what I'm saying? So I apologize to those. But the bottom line is we still have two doctors in the building. One is going to converse about one thing, and one's going to converse about another. So with that being said, tonight's episode, the show is we're going to talk extensively, I guess, about diabetes and prostate cancer, or just getting tested for prostate. I personally understand these situations. One, I lost my father and my uncle, and a few uncles to prostate. That was a segue. I am a diabetic, which my mother was. Also, too, I've just had some little things. I had to check out my prostate. So that things with that magnitude, this is a great time, an issue, especially with food coming up, especially with men reaching a certain age. These are topics that are definitely important. the diabetes is something that we should talk about all the time, especially with the holidays. People are going to be drinking, eating sweets. Oh, you know, coconut custard pie,
full disclosure,
sweet potato pie.
Full disclosure.
Oh,
One thing that Bill and I have in common is we both love coconut custard pie.
Yes, we do.
Okay.
Yeah. So once or twice a year, we splurge and we share a pie. So
Mine is sweet potato pie. So, but you guys got it. Good pie.
We have that. We actually have that too here, Jay.
Yeah, man. Yeah.
Yes, I understand.
It's all good.
Mm-hmm.
I understand.
But I'm glad we're having going to have this conversation. It's so important. And I was just thinking how busy life is for all of us, right? Theresa, we were just talking about work and just life in general is so busy. And a lot of times people forget or just skip over their own self-care and health and checkups. So I think that this should hopefully serve as a reminder for people to take time for yourself and slow down and get yourself checked out.
Hey, Vera, with the wonderful shout out to everybody that's chiming in. Vera with the wonderful last name, Foster. We love you. If anybody has any questions during the course of the show, please type them in and stuff like that. And somebody, I think, either turn down the volume on your phone or mute it. James, before we go on, you are a doctor. Just tell people your background and what's your profession of trade. And if you, I don't know if you see clients and stuff like that, but go ahead, please.
Sure. Yes. Like you said, I'm an MD, but I practice psychiatry typically. I do see clients. I work for a particular agency here in the city in Harlem called Cases, and we do a lot of community psychiatry, which I really never thought that I would necessarily enjoy that, but I enjoy it tremendously. It gives a lot to the community. We actually meet people where they are in the community in needing mental health. And I work with a nurse and LPN, and we provide medical services also to those clients out in the community. Like you said, if they're diabetic or whatever, monitoring them, their blood sugars and things like that. So we kind of have a holistic approach to providing service to patients in the community.
So that's very interesting that you said that, because you said dogs. I'm come out there in a minute. Let me stop. Right, I don't want them dogs to get this smoke and get these hands. No, I'm jokingly. Let's talk about that from a psychological standpoint. When you're dealing with people that are developing illnesses, or you find out that they have illnesses, and Theresa, you can piggyback. Of course, Malika definitely can chime in with this.
Yes,
that does have to take a psychological toll on a person too, right?
You mean as far as treating those individuals?
No, I'm just talking about when the person finds out they have certain illnesses.
Yes.
Depending on the stages of the illness.
Certainly, yes.
Yeah.
Well, you're right. And of course, there's a lot of stigma if you talk about, particularly a lot of illnesses, but particularly mental illnesses. But even like you said, even diabetes. People can have very difficulty time, as Theresa can tell you, accepting that they have diabetes, or they have, bipolar disorder, or they have depression, or they have schizophrenia, or whatever. So it can be very difficult. A lot of times it has to do with the stigma of having a particular illness. We all want to present that we're very healthy and that we're doing well, but sometimes illnesses do creep up on us, whether it be to genetics or, circumstances in our life or what have you. Things happen. So, and it is difficult sometimes to accept. Sometimes my job is to help people accept. This is where you are. This is where we are. And we're gonna treat this, and you're gonna do well with it.
So funny. Yes, go ahead, Theresa, please.
I'm sorry. I had promised Dr. McKnight to come on for a brief period of time.
Oh, sure.
Because he's got other things he has to do, and I just want to be true to my word so that he can do this, and then maybe we can have him come back for.
Oh no, I apologize, James. I mean, I apologize, everybody out there that's listening. This is a family kind of conversation, especially.
Sure. No, I'm fine. Yes, I understand.
So this is the living room with.
Yeah. So the thing is, I just, because of his professionalism, I just delved into that from a journalistic standpoint. But
Sure.
Theresa, please segue and then and go forth and do what you need to do. Go ahead.
Okay. So I have a few brief questions that I'd like to ask Dr. McKnight, and then if there are any questions afterwards, he would be available for a few. If he leaves, then you can let me know and I can get the answers back for you.
Sure.
Okay. But Dr. McKnight, you recently spoke at an inaugural men's conference on mental and physical health. How did that come about?
Well, in my early days of my career, I worked at the Fulton County Jail, and you guys are familiar with the Fulton County Jail. It's very famous now. Fannie Willis made it very famous with what happened down there in Atlanta, Georgia. So I worked there, and when I came back to New York, also I did some consulting work, and I worked at Rikers. And so when the call came out that the Correctional Officers Department needed a speaker, since I had worked alongside of correction officers quite a bit, and I knew the long hours that they work, very stressful job. I mean, being a correction officer is quite stressful. I decided that I wanted to maybe give back and talk to them a little bit. Also, I can kind of remember also is that when I was working at Rikers, I had gotten very lax and kind of was just walking around the jail, just kind of moving up and down the stairs and what have you. And one of the correction officers stopped me and said, "Dr. McKnight, you need to stop walking around here just like whatever. So you need an escort, something can go down." And so I really appreciate him taking care of me and stopping me at that point. So I said, you know what? I'm going to give back and maybe speak to them a little bit about the need for them to get their physical examinations and get their screenings, which includes not only taking care of their mental health, but their physical health and seeing our urologists. Now, Bill, when I say a urologist, what do we think? We think the finger. So many have a difficult time with that, but it's such an important thing that we need to do to take care of ourselves,
Okay.
And like Bill, go ahead.
I'm sorry. So during that talk, you had just seen a urologist and you had mentioned that and a need to get an MRI, and you shared those results at this conference. Why was that?
Well, I think that it's important for us sometimes to just put it out there, and sometimes if it can help one person, one young man or older man to kind of decide to take care of themselves and go see a urologist, get an exam done, it's well worth it. I had, prostate cancer can be quite deadly, particularly among African American men. It's said that if we live long enough, that 100% of us will develop prostate cancer. And I had maybe about a couple of years ago, I had posted it on Facebook that my PSA was 25, which is way high, believe it or not.
Wow.
But yes, it was really 25. So really, you don't want to go over 4. Most people, it's 0.1, 0.2, it's really, really low. So when it gets up there, that's pretty significant. But I posted it.
That number is the PSA? Is that
what?
Right.
Okay. Yes, the specific antigen that we'll talk a little bit about. So and then I found myself that here it is a week or two ago, I'm sitting in front of a new urologist. He's telling me that my results is 15 and that we needed to repeat the MRI. Initially, I kind of went back and forth and said, well, I do a lot of spinning. I work out a lot because in the literature, in the health literature, it says that if you spin, you work out a lot, whatever, that can kind of increase your PSA. So I kind of went back and forth with him with that. And he was like, no, we really need to, we need to repeat your MRI. And so, it's always kind of a scary thing when you're facing cancer or things like that. And like Bill mentioned, he lost people. I've lost an uncle. I've had friends who developed prostate cancer. So, but I decided to go ahead and do it. And I decided to share it.
Okay.
And
okay.
It was, yeah.
All right. So thank you. Now, there are 3 specific illnesses that can happen to the prostate. Can you just briefly tell us what those 3 are?
Sure. Prostatitis. And, of course, the itis is inflammation. So this can happen to all men, all ages. Believe it or not, some 2 billion men a year suffer with maybe a chronic or acute prostatitis. And it's really benign. It's non-cancerous. It's typically secondary to a bacterial infection of some type that may get into the system, maybe from the rectum or what have you. or a patient may have a urinary tract infection. Theresa, you know those quite a bit. Trauma to your scrotum, somebody kick you in your scrotum, or it can happen, or you have an enlarged prostate. All of this can contribute to you developing prostatitis. Like I said, it's not contagious. It's not an STD. Some of the symptoms people may have is maybe urgency, feeling like they have to go to the bathroom a lot, some burning, lower back pain, even loss of sex drives can happen with prostatitis. So, you certainly want to get this treated. And if it's caused by bacterial infection, then you might want to get an antibiotic, other antimicrobials, if it's fungal or whatever, viral or whatever infection, you can get it treated. So that's one thing that can happen. The most common type of problem with the prostate is what we call benign prostatic hyperplasia. And that just means the enlargement of the prostate. And I think that most men have heard that, particularly among Black men. They often say we have enlarged our prostates. And typically our prostate grow, usually it starts off maybe with the side of a walnut, and over years it kind of gradually grows. Typically around the age, during puberty, of course, all those hormones hit, it kind of grows a little bit. And then at age of 25, for some reason, they said it kind of grows. And then after 40, then that's when it kind of just gradually just continues to kind of grow. Your prostate is kind of growing. So benign prostatic hyperplasia is quite common among men. And those of us who are up in age, you will typically have kind of an enlarged prostate. Some of the symptoms that you may experience is urgency. Have to go to the bathroom a lot, frequency. Vanessa often say, James, you go to the bathroom quite a bit. You may have a slow flow, some dribbling, difficulty urinating, things like that. But the interesting thing about benign prostatic hyperplasia, or BPH is what is that it's not, it doesn't increase your risk of cancer at all. Not necessarily. No, it's benign. All right. And there are certain medications that people can, doctors can give you to kind of help you with your flow, your urine flow, which is really great. Now, the third thing, of course, is what we're here kind of talking about, and that's when we talk about having prostate cancer of the prostate. And this is when you get cancer of the prostate, you can do some testing and all that, MRIs, but to really make the diagnosis, of course, is you need to do a biopsy. So your urologist usually will set you up, and they will, do a biopsy, what have you. Why do some men get prostate and why others? Of course, that's any particular cancer. We can certainly look at the risk factors. What are some of the risk factors to getting prostatic cancer? Advanced age, 50 and above, which a lot of us are. Being an African-American male, they said we typically we're twice as likely to develop prostatic cancer compared to white men. Having a family history, if you had a brother, uncle, or someone who developed prostatic cancer kind of at an early age, genetics is playing a part here, then you have an increased risk. Smoking increases the risk. Obesity, eating a high-fat diet, and living a sedentary lifestyle. All of those increase the risk of an individual developing prostate cancer. Getting this can be quite difficult. Getting this diagnosis can be horrifying, of course, for any of us, cancer diagnosis. But you know what? Through early detection, they have new medications. They have all kinds of treatment we see on television now, the cyber knife and all kinds of things like this. The survival rate is quite high now. Up to 98% of the men can live and maybe die of something else outside of cancer. Prostatic cancer. So you can do quite well if with early detection, you get caught early, you get treatment, you get it treated, you can do quite well. So that's the great news behind prostate cancer.
Okay, and so Dr. McKnight, you told us things that could increase. So in terms of decreasing the risk, is that with your exercise and eating healthy and taking supplements?
Definitely. Well, definitely exercising regularly, getting a good, sleeping well, eating healthy, all of those things, just the opposite of some of those other things that we mentioned, can certainly help. For years, I've been taking vitamin D3, some omega fatty acids. So they all, reports that decreases your decreases your ability to get cancer. So I've been doing some of those things. Of course, I exercise quite a bit, things like that. So all of those things can kind of help with decreasing your risk of developing prostatic cancer. Definitely.
Okay. All right. So, Dr. McKnight, I want to thank you for coming on. I asked him at the last moment. I appreciate this. And we'll let him leave. And then if there are any other questions,
Hold
Dr.
on.
McKnight, I'll let you know. And we'll also have a urologist.
Hold on. James, you got a few minutes because there's a question that a couple of people, I'm sure one question is for Theresa and you, but my brother Malcolm has a question. It might be off the beaten path, but I definitely know what he's talking about because we grew up together and I went through this with him. So this is his question.
Oh, he wanted to talk about bipolar and schizophrenia?
Yes.
Sure. Certainly. Those are certainly two different illnesses. Bipolar disorder, as stated there, bipolar, the two different poles. And the different poles that we're talking about there typically is you have manic pole and you have a depressive pole. Individuals who are bipolar typically can get very, very depressed, or they can become manic, or what we call hypomanic. Now, you cannot be diagnosed with bipolar disorder unless you've had a manic episode or hypomanic episode. And what does that look like? Typically, individuals who can't sleep at night, their mind is racing, they're easily distracted, poor decision makings around money. For example, I had a patient who was bipolar and she was very wealthy. She bought like 8 Jaguars in one day. I mean, so they're just making poor decisions around things like that. And then they have periods where they get extremely depressed. Bipolars have the highest rate of suicide, so they certainly can kill themselves, and the highest rate of substance abuse. Now, we talk about schizophrenia. Schizophrenia is a different illness that we're talking here. Schizophrenia is a chronic mental illness also, and usually we're talking about individuals who are not in touch with reality at all. They can exhibit auditory or visual hallucinations, seeing things, hearing things, but also they usually have disorganization in thought and in behavior. Sometimes you see people out in the street just wandering around, just doing things or whatever, and just very disorganized, what have you. Schizophrenia affects approximately 1% of the population, more common in men. And particularly today, we often educate our residents that for some reason, African-American males are often diagnosed more with schizophrenia, a more severe illness. This is one of the most severe illnesses of mental illnesses. We're doing better with treatment of mental health. We have medications now that can help. We know that particularly with schizophrenia, it has to do with dopamine levels in the brain. High levels of dopamine can cause a person to be psychotic, hear voices, see things, what have you. So the medications we use are what we call anti-dopaminergic, meaning it decreases the amount of dopamine in the brain. And in decreasing that dopamine can kind of help the patient do better. We have a host of medications that we also use to treat bipolar disorder, various affecting a lot of the brain hormones and so forth. So very two distinct illnesses. I deal with both of them daily. The one with the best prognosis is bipolar disorder. Those individuals can do quite well. In fact, a lot of actors and creative people may have bipolar disorder, and they can do quite well.
Thank you. I appreciate that. Malcolm, I hope that answered your question. If not, I'm sure you two will meet in the near future where you can have a more extensive conversation. And if you need to speak to him in regards to that, I mean, if Pops is deceased, so I know that, but it's still something that lingers in his soul and his spirit, as that's my brother that we grew up together. So there's
I'll be happy to come back another time to talk.
Oh, absolutely. Okay. Now, this is a question. I don't know if you got to go, James. Maybe Theresa, we could leave. James, I'll let you go. We'll talk soon. Sure. Theresa, I'm gonna put this question up for you. Thank you, James.
Welcome.
James.
You guys take care. See you guys during the holidays.
Okay. All right, you too.
Bye-bye.
Exactly. Bye-bye. All right, Theresa, this question is for you because we're going to stay on these two topics.
Okay. Right. I saw that where Ms. Francois said her uncle has stage 4 prostate cancer. Any advice? I'm not a urologist, but any of my patients that have cancer, what we need to know is when they have the biopsy, they stage it in terms of two things: a Gleason score and then what they actually see on the biopsy. So from what I understand, and we'll have a urologist come in, but a Gleason's,
Excellent.
I'm sorry?
I said that's excellent if you have a urologist come on. That'll be excellent. Thank you. Yeah.
Well, a Gleason score means that when they looked at the cells, they weren't dividing rapidly and that they were contained. And they think that if you have a Gleason score of less than 6, that you don't need to have treatment for prostate cancer other than AS, which is active surveillance. So every 6 months, they would do a PSA, and as long as that PSA stayed fine, you didn't have to have any different treatments. So a stage 4 prostate cancer, I don't particularly know what that is now, because stage 4 before meant, and this is what we'll have to ask the urologist, that it had come outside of the prostate and had either attacked the bones or had some kind of, we call it metastasis, where that prostate cancer went to the bone. So the advice, Ms. Francois, you can ask, I would have my uncle have the urologist talk to you, or you go with him to an appointment. You can get what he's saying, and then you can bring it back to us, and we can further discuss it and have a discussion with the urologist. So yeah, so a stage 4 is still the same as what I remember. It affects other organs. It's outside of the prostate. So he had lungs and bone. Mm-hmm. And how is your uncle doing? And do you know what his treatment is?
One quick question for you, Theresa, because I think I heard James mention that his PSA level was high of 25.
Yeah, that's high.
Like, what is the normal range?
No. I haven't seen that high. Most of the time, it should be less than 4. Okay, and sometimes it can be just mildly elevated at 5. Mm-hmm. For African American men in particular, if I see 5 and I send them to the urologist, if your prostate is enlarged, which means you will go to the bathroom a lot, we call that frequency. You get up at night more than 2 or 3 times. That's called nocturia. Those are reasons that the prostate could be enlarged, and it's not cancer. But anything over 4, you need to send them to the urologist. So either it can be an MRI and a biopsy.
That's interesting, because I think, from what I was hearing James say, and just general research, mm-hmm. when I hear a high number for prostate, I automatically thought, oh, that meant prostate cancer.
No.
But learning something new, that's not the case. Right?
It doesn't. And I do have a couple of patients who have prostate levels that are 12. And they've done the mm-hmm. MRI and they've done the biopsy. And they don't want any treatment. Okay, it's contained. It's got this Gleason. Even though that prostate number is high, they're actually just doing AS, active surveillance.
Right.
One patient of mine that was recent, I hadn't seen him in a while. And he said, oh, but my urologist is doing everything. And he said, everything is fine. And I knew his PSA was like 12. And I said, he said, it's fine. Well, let me talk to him. Mm-hmm. When I talked to him, He said, no, he has prostate cancer. He's had prostate cancer for 12 years. Okay. The PSA stays at the same. We're actually doing active surveillance. And he said, but I want him to do another biopsy, not another MRI, just another biopsy so we can stage it. And so I went to my patient and I said, well, yes, I can see how you would say everything is fine, but he does say you have prostate cancer and he would like to do another biopsy. And he said that would interfere with my life. I'm active. I do all of these things. It means I would have to take off a week or two, to have the procedure done. And so, no, I'm not interested in that. And so I said, okay. So we left it. He's going to come back to me in a couple of weeks, and I'm going to see how he feels. And I'm actually going to talk and see what is the level or that he would have to be out. But to your point, Malika, a high PSA, you would think that it automatically is cancer. This guy does have cancer, and it has been contained for 12 years. And so sometimes as a physician, I got to really listen to the patient. Okay. I may not actually agree with that, but just give them the information, because it should be a partnership. But I did express to him, I don't see anything wrong with the biopsy. Nobody's telling you got to have radiation and surgery and all that. We just need to see where it is. And when I was thinking about this, I had another patient who wrote something, and I just wanted to read it. He said, the key to defeating prostate cancer is early detection. He said, in my case, I was tested for prostate cancer in 2023. Results were negative. 1 year later, in 2024, at an annual physical, I had stage 1 prostate cancer. So all men 40 years and above should be tested annually for prostate cancer, just as we annually file taxes, vote, celebrate weddings, birthdays, watch the Super Bowl, NCAA, March Madness, the NBA championship, and World Series. Men need to get tested for prostate cancer. And he goes on to tell me too many men resist regular doctor's visits because of the stigma of acknowledging illness. The assertion that visiting the doctor on a regular basis marginalizes one's masculinity, and it invokes the fear of the unknown about our health and our longevity. And he goes on to say he wants to make this personal appeal, particularly to Black men, to get tested annually. And he said too many Black men tend to ignore regular medical checkups, discount bodily signs of pain and unusual physical occurrences. So to all men, I say, don't get tested or treated for prostate cancer for yourself. Do it for those you love and for those that love you. And so he sent this to me, and I said, I'm going to say, talk to different patients about it, because I think he humanized it. And then when James was on, so I think we want to say early detection, and I will let you know, Bill and Malika, when I can get this urologist back on.
Please, I think you're right, sweetie. I think that's very important, and full transparency to what Stefania put out there, and I'm going to put her other questions on. Is that the fact that my father had prostate cancer and he didn't do anything about it, and that's a whole nother psychological thing for African American men, or just men in general. I think men, like you said, early detection is a beautiful thing, and I'm assuming at the time it was early detection for him, but for some reason he didn't do anything about it. And then later on, I'm assuming it went to stage 4 as Stefania's uncle, but I hope it's not as severe as her uncle, my father was. And then it spread to bone cancer.
Okay.
Right. And then that's when they said he only had 2 years to live. So for me, always looking at my father and I was like, yo, like, dog, like what did you do or what did you not do? Because I mean, that's a whole nother page and another chapter on why men, I don't know if it's about African American men or men of color or just men in general, at that time, back in the earlier age, didn't go handle their business at the doctor's office. So I do my due diligence all the time and stay on top of my thing. And recently I just had to do this for myself. And as you know, but I have no problems being like full disclosure, because that's what real talk is to me, to let people know that you still have to go out here and do your due diligence and stuff like that. I'm going to put Stefania's statement out right now for you. What's up, my brother Norman Seabrook? We need to bring you in very soon. Go ahead.
Okay. Yes, Miss Francois, he's on medication now. And so that medication may be just to decrease the PSA. They're saying no chemo or radiation because, yes, it has spread, but it's not going to contain it. And then he would have side effects from the chemo and the radiation. And that's the thing I also want to say to Bill about your father, because in that era, the treatments for the disease were sometimes worse than the disease itself.
Absolutely.
It's just like with HIV, when we didn't have the proper and the drugs that we have now. People, we would say we need to be treated, and it was like, no, not with that AZT. I saw so many people die, blah blah blah. I don't want it. Okay, and so you have to look at the time that it was. People may choose that I don't want to have a serious side effect that may be worse than the disease. And what they feel is that if I am going to perish anyway, let me have control over how I want to do it.
Yes, absolutely. Everybody, this is Real Talk Chronicles. My host, Malika Forster, and myself, and of course with our other co-host, Theresa and Mack. Thank you to Dr. James McKnight for chiming in. Right before the holidays, we ain't trying to put a Debbie Downer on you. No disrespect to anybody named Debbie. You know what I'm saying? But it's a slogan and it's a terminology. But we just want you to be all cognizant of what you have to do, especially men of a certain age. And Theresa, we can go into that and talk about that. And shout out to my man, brother Norman Seabrook. Norman, we got to get you in very soon to talk about what's going on, whether you're hearing in regards to corrections. We could talk politics. That's my brother Norman Seabrook, probably one of the best union individuals that's ever walked the face of the earth, my man Norman Seabrook. Also, too, let's just discuss when we talk about prostate, we talk about health, we talk about diabetes. Like there was, I got a brain freeze for just a second on what we were about to talk about in regards. If anybody has questions, please chime in, say what it is at these ages. So that was my question for prostate. What's the age when a person should first get tested? I think what people used to say 50 and stuff like that with colonoscopies and stuff like that, but I don't know if prostates and colonoscopies kind of go hand in hand with each other. Go ahead.
The new recommendations have changed. For Africa, it is 50 by our national guidelines, but for African Americans, we start at 40. Okay, wow. For the PSA, and also for colon cancer. It used to be 50. We now start at 45 because early detection, okay, is the key. If something is small and it can be contained, that is much, much better.
Understood. Let me. I think Norman has a question, and I think we have a
Sure.
couple of questions in here.
Okay. Oh no, that makes perfectly good sense. Yes, I do agree with that, but I think for that to happen, it would need to be you'd have to change the laws, and you would have to have someone with medical background to say that let's get these mandatory screenings done, and that the trade-off is that when you retire, you're not sick. A lot of people who retire, and I've seen this in my practice, is that they work, retire, then they decide to go and get their health checked. And by then, it's something that's gone wrong. And so either, you're retired, but now you're spending all of your time not doing what you thought you could do. But again, taking care of that disease, and that is insurance and thousands in medical bills. So I like that, but I don't know. Everybody hates the word mandatory. But sometimes, as a physician, sometimes I do wish that things were mandatory, because it would help in the long run for them to have better productive lives. And insurances, that's a whole different ball game, which I get very angry at how they treat us sometimes. But
so Theresa, Norman said you're hired.
Listen, I'm a lobby for my brother Norman to run for political office eventually, very soon. Yeah, but listen, also too, everybody out there, just full transparency. Theresa, Dr. Mack is a practicing physician in New York City right now. If you want to know where she is, if she's still taking clients, we will ask her to divulge that information. She's done it already in the past, but the bottom line is this is about supporting us. I'm promoting her. She's promoting me. We're promoting each other, right? This is what we're going to do. That's our sister, and that's a family member to us. So this is what we do. I'm big her and her husband up, just also like Dr. McKnight, we big him up. So, listen, we got doctors. We got people in our corner that got some knowledge. You know what I'm saying?
No, I appreciate that, but I've told you before that this is I love your format, because you can reach people and people can talk to us. Sometimes in an office, you have a 20-minute limit. You can't do everything, that you want. It has to be in stages. So I very much like this format.
This is your format, Doc. This is your format.
The living room with Theresa Mack. Okay.
Exactly.
But I am in Harlem. I am at 2771 Frederick Douglass Boulevard. That's 8th Avenue, at the corner of 147th Street. And yes, I am taking new patients. So 212-523-8672.
We'll put that in before the night's over. So you can go back and look at it on YouTube or Facebook Live. We have another question from Gary.
I see this one. Okay, is BPH something to be concerned about? Only if it's causing you symptoms. And so what could be the symptoms? Say, for instance, every hour on the hour you're urinating, okay? And you have a job that's an inconvenience. Or at night, you're going to sleep, and again, every 15, 20 minutes, you're getting up, going to the bathroom. That's something to be concerned about, because that's affecting your quality of life. But BPH, as Dr. McKnight said, is benign prostate hyperplasia. It doesn't turn into cancer. So if people say, well, I got BPH, I'll live with it. But there are medicines that you could take that would decrease that urine flow so that you're not doing that. So is it something to be concerned about? I say yes for your symptoms, but no, that it won't turn into prostate cancer.
Now, let me piggyback off that question. Excuse me. I was under the impression that as men got older, or I don't know if it's men or women, or just anybody, that you just had to go to the bathroom in the middle of the night. That's not true. You just
No.
You're like, I gotta go to the bathroom. You didn't urinate before you went to the bed. You drank too much or whatever it was. I just figured you just old. Be like, yo, you
drink a lot of water.
You set your clock watch. Next thing you know, you be like,
happens.
Yeah. Full transparency, a funny joke. Malika got up the other night. She said, oh my God, it's a certain time. I said, oh, what time is it? She said, I think it's 4 or 5 o'clock in the morning. I said, okay. This is what happens when you go to bed early for all you youngins, but older people understand it. So we went to bed early, like it was like 9 o'clock, right? Something like that. We were so tired. So I said, oh my God, it's 4 o'clock. We got to take the dogs out. We got to do this. So I go and I look at the phone and I looked at the clock. I said, Malika, it's 2 o'clock. She said, oh, my bad. So I just got up and went to the bathroom anyway because I was just already up. So full transparency. Let me read. Also, Stefania says this, and then I got another.
I think Gary had a question about the weak urine.
Mm-hmm. Is it generic?
No.
Oh.
Wait a minute. I see something that says urine stream. What about the urine stream being weak sometimes? Yes, that could be a symptom of BPH. And if that's the case, the urologist can open up that duct with the prostate, and so that you don't have a weak stream.
Mm-hmm.
Oh, yeah.
And what was the question about genetics?
Yes, we were just trying to find it.
Go up. Go up.
Okay. We were just talking about that.
Right there.
Okay.
Oh, I see it here. Okay.
Okay. My dad also has, so I guess it's genetic. No, how can I say?
Real talk. Just say it. Real talk. Let it out.
So if anytime someone has prostate cancer or any cancer in the family, say your mother had breast cancer, we take that to mean that you may have the gene, but we don't know because we don't look at the whole genetic code. But what we would do is say that for the brothers that you have, you should be tested for prostate cancer. For mothers who've had breast cancer, all of the children should be tested for breast cancer and to see if they have a breast cancer gene. And again, for colon cancer, if someone has colon cancer, their parent, then we start testing them, say 10 years before that, the patient who had the cancer. So for example, if their father or mother had colon cancer at 40, I told you we start screening at 45. We would then start screening that particular person at 30. And so we don't have, and that's why the history is so important. If people know their history and can tell us, because 30 is a big difference from 45. Okay. And
let me ask you a question. Okay, I'm sorry. Go ahead, please.
No, we can also do the colon cancer gene. So we can look at a breast cancer gene, a colon cancer gene. I'm sorry. What were you going to ask?
No, I apologize to you. When people start talking about things that are hereditary, right? we could talk about recession of hair, or we could talk about feet. We could talk about a lot of things that people say are. But when we start talking about certain illnesses, just like Stefania just asked about genetic prostate cancer and stuff like that, like diabetes. So what things that we have to keep, or is just anything that, because anytime you go to a doctor or a new doctor or old doctor, they always find out what did your family members suffer, illnesses were. So I guess, is that test oriented, or that's just like you become the lab baby, like, or is there some validity to, you know what I'm saying? Like,
Yeah,
breast cancer. Yeah.
There is validity. So Ms. Francois said, I guess it's genetic, but it puts us on a path so that we would do things a little bit earlier than before. And yes, things, once we learn about genetics, there is a whole field of science that we're calling epigenetics. And epigenetics goes and looks how you adapted, say during slavery, and what things you had to avoid, and then how it is manifested now. And that epigenetics turns on one of your hormones called stress, a stress hormone of cortisol. So they're looking at epigenetics and seeing that sometimes based on what your history was or what it was in the past, from generations, that you're having this. And so that'll be a topic that I will research a little bit more for you and bring to the living room. But in my particular family case, my mother had 10 brothers and sisters, and their mother and father had diabetes. The 10 brothers and sisters all had diabetes, and it was insulin dependent. And if they didn't have diabetes, they had kidney problems. And then their children haven't had diabetes, because we're now in an age where we go to the doctor. We now have the pre-diabetes. We now have to get active. And so we are trying to do things so that it doesn't come to that particular illness.
Thank you, Doc. I appreciate that, because I think with so many different things are deemed hereditary and we don't know what they are. I just got some comments and questions, and I'm going to go scroll to them, and then maybe we're going to scroll.
Norman's comment up top.
Yeah, absolutely. And then we're going to, that's right there. I just want to make sure. And then we're going to talk about some diabetic stuff.
Okay. Wait, yes. Yeah. Mrs. Seabrook, that is so very, very important. And I've had a couple of patients come to me in the past week saying, I'm going to retire in a year. So please make sure I get everything that I need. And one patient told me she retired, and then all of the tests that we were doing for screenings, she said they don't cover them anymore. And so she has to like piecemeal, which one she is going to do. So that is a very, very good point that I think people who are retiring need to know. What is their insurance coverage? Is it going to change? And what does it cover?
Absolutely. Next question. Thank you, Brother Norm. I don't know about that.
Did that one.
Oh, did we do this one already?
Yeah.
Oh, okay, my bad. Your fault, my mistake. So let's go to the next one. She says, Stefania says this. I'm just reading.
Oh, I like intermittent fasting.
Mhm.
The question is, as a physician, what are your thoughts on intermittent fasting? I like intermittent fasting as opposed to fasting where you do one a day or 2 days or 3 days. Um, but intermittent fasting, how it works is that if you divide the day into 24 hours, you're only going to eat during 8 hours. So that could be that you would wake up, say at 6 o'clock, but you're not a breakfast person. So you're only going to start eating at 12. And at 12, you start eating, and you can eat between 12 to 8. And you can have your 3 meals or 2 meals and a snack during that period of time. And then at 8 p.m., through the rest of the night to the next day at 12 p.m., you're not eating. And so, what that forces your body to do is when you're not eating and you still have to have energy, your body then goes to the fat stores. And so, your body is using fat for energy. And so that's why I think it's more of a helpful way to fast. And if you can do it, it's perfect. It really is on a physiologic, I think, one of the better ways. Who asked that question? And have you tried it?
That was Stefania.
That was Stefania.
Ah,
I
okay.
think
Have
she's
you
skinny
tried it,
anyway.
Ms. Francois?
I think she's skinny anyway, but everybody wants to lose another pound or two.
Why
For
did
the-
she ask? Why did you ask?
what happened?
She's
I wanted to
asking
know
Stefania.
why did she ask about intermittent fasting?
You just asked her. Go ahead.
I was going to take a jab at Stefania. How many years have we been doing this?
Yeah,
Like
we're
4
trying to
years?
say it. We're trying to get her to come to
Haven't
Grow House and
seen
show
you
us.
yet,
Haven't seen you fun
Stefania.
yet. But you know what's so funny? I think intermittent fasting is a good
It's
thing.
awesome.
I think we've lost weight doing it. I think we did it not intentionally, but I started doing it, and I was like, well, wait a minute.
I do it intentionally.
Oh, you did it intentionally, but I did it because that's just the way my eating habits are. So it just worked perfectly for me.
Mm-hmm.
So I'm at a good numbers. I mean, I want to be better. I mean, it's already, I ain't body by Jake, but I sure ain't body by Bud. You know what I'm saying? But I know one thing: I can have some coconut custard pie and some sweet potato pie this Thursday.
Thing with intermittent fasting, the time that you eat, though, it has to still be good, healthy habits. You can't say from 12 to 8, I'm going to have cake, I'm going to have potato chips, I might have a sandwich, might have something fried. No, it still has to be good, wholesome food.
I think people have the misnomer that you could just eat anything you want to between 12 and 8. No, exactly. You still got to have some kind of,
And there's nothing wrong with having your custard pie. Okay. You don't do it every day. You don't do it every day. And so that's your treat.
Yes.
Okay.
Gary says, go ahead.
I can see now. This one I can see is inevitable. I wouldn't say it's inevitable that the prostate will grow, but it does. Okay. This is a question I'm gonna write it down. We can ask the urologist. Okay. But I don't think it's okay.
And she writes that down. Everybody, this is Real Talk Chronicles. I'm your host, Bill Forster, with my co-host Malika Forster, and our other co-host, Dr. Theresa Mack. And this segment is the living room, as the doctor so states. Listen, we try to give you the best content on the second Monday of the month. We have Dr. Marilyn Quarter. We got doctors that's coming in here, chiming in with you.
I love it.
Every Wednesday, for the most part, we try to give you some thought-provocative stuff. That's where we're going to bring Norm back in. and we talk a lot about police issues, the politics. What is your thoughts on the government, the cabinet, things of that magnitude? You know, it's so funny. Everybody has a right to their own opinion. Just if you feel like expressing it, join the panel, or just come in. So, you know, I ask you to like it, share it, subscribe to it, right?
Yes.
If you're on Facebook, I don't care where you watch it at, but go to YouTube and subscribe. Give me a thumbs up and stuff like that, so we can know, because positivity, it seems like it's the hardest thing to sell. Malika doesn't like when I say that, but I always say that. I could talk about.
Say what you want.
I said it. But you know what the bottom line is? We try to give you
Yes.
the best content we can, along with the doctors. This is the one, like you said, like Dr. Mack said, you don't get that avenue to converse with your patients and people. So take the opportunity, do it, listen to her. She asks questions. Well, like she's here once a month. We're going to get her husband back. We're going to get Dr. McKnight back. So there's a lot of things going on. Health issues are prevalent, especially from the psychological standpoint of things, right? Within this community. We could talk about that. I have my own personal feelings from a law enforcement standpoint, but just from a man in general, you know, when we start talking about mental illness and things of that magnitude. I know Norm has a lot of things from a correctional standpoint. Theresa, what's your thoughts on that, what he just asked? And then
Mr. Seabrook, what are you asking about 9/11? The illnesses that occur, the medical management of that, because there are diseases that are still around from all of the trauma that people had during 9/11. I have a lot of patients that when I see that they have gone to a World Trade Center doctor, I kind of make it my point to ask, well, where were you? What were you doing? And it's amazing where they were, that no one knew anything, and you're trying to help someone. And here it is, 2024, they still have post-traumatic stress like it was yesterday. Okay.
Yeah.
And then the other is the cancers that start cropping up. Never before had cancers, or their family was healthy, and then all of a sudden you're getting head and neck cancers, you're getting cancers all over your body. So it's 9/11 definitely was a travesty, and we're still seeing those effects. What do you mean by what are my thoughts?
He said yes. I think whatever you said, he replied yes to. I guess there was whatever caption you or statement that you said, whatever question you may have asked him in regards to 9/11, he
that
replied,
was what he was referring to.
That's what he was referring to. We might have to go back and bring that back up. So go ahead. Malika has a question for your statement.
Oh yeah, we have 3 more. I know we're over time. We usually cut at 8, but we just have 3 more. If we can just hit these 3, and then we'll close out for tonight.
And then the thing is, like I said, everybody come back, chime in. Please, you're always more than welcome to join the podcast at any given time. I appreciate the input. Norm, you know, you're always welcome. You know, we got to get you on either with the Wednesday crew or by yourself. Maybe Norm right now. Monday is kind of open. Maybe we could just have real talk with Norman Seabrook and stuff like that. Go ahead.
Stefania's question.
Yeah, no, I have not heard of this. She's asking, there's research going on about Alzheimer's, saying that it's a type 3 diabetes, but I will look that up, and when I come back, I'll bring you some information.
Great.
What about Pearl?
And Pearline has.
Shout out to Miss Pearl in the building.
Pearl. My mother, both of her parents, all of her siblings, including me. Okay. Yes, but now, do you exercise?
As we kind of know that answer on.
Right.
Exactly.
So she's taking care of herself. Okay.
Right.
But it is when you see long families like this with a history of diabetes, that means you have to go over and beyond. You got to exercise very well. You're at your ideal weight. You are exercising, and you're living a happy, healthy life.
We're going to pick this up too. I know we're going to give you 5 more minutes because I don't want to keep you past that time. Well, we already went past that time, but I'm just going to say 5 more minutes. But the thing is, we're going to pick up this conversation again, and you'll let us know if you got when you get the urologist in. But the thing is, doctors have always said with diabetes, it can affect the kidneys, correct?
Yes. Yes.
Okay. Because I mean, I know that's some of the medicine that I take, and I mean, I got my numbers back, everything was fine. So I think there's so many different things, and we'll probably have to touch on that again, how diabetes can affect. It's like the tree in the ground, but the branches go everywhere. Like I'm learning more and more every day about how diabetes can affect this limb, can affect that, can affect this, can affect that, the urine, the not the prostate, but just the eyes, the limb.
The vessels in the eyes are the same caliber as the vessels in the kidney. And so when someone has diabetic kidney disease, we automatically look at their eyes because they may have it there and we need to do things to arrest it. So when we come back, we will talk, in addition, just diabetes and some of the complications and what you can do about it.
And just full transparency, glaucoma comes from diabetes, correct? In regards to that?
No. You can have cataracts and diabetes. You can have cataracts and glaucoma in diabetes, but glaucoma is caused by increased eye pressure, not increased sugar.
So it's totally different, because I think a lot of times people will say glaucoma, diabetes. So I'm glad you put clarity to that. I'm glad you did. Yeah. I'm just going to read some of these comments. As Pearl Norman says, "God bless you and have a wonderful Thanksgiving, Don."
Oh, thank you. You too.
Pearline, she says, "Well, yes, and I dropped my A1C 10 points 6 days a week."
Okay, dropped it from what
to what? Yeah, 10 points. Yeah.
Yes. Yeah. How high was it, and what is it now?
Exactly. Let me show the next question as we get ready to get out of here. Great show, very informative subject to discuss. Thank you. We're on 4 minutes and counting down. Pearline says, "Can diet generations of youth and my family change the generics? I tell my son."
Yeah, no. You can. That's what I'm saying. You have to make an extra effort. So yes, you need to exercise more. You need to eat properly. If you're not at your right weight, you need to get at the right weight. And yes, you can kind of fool the body, I would say. Just because everybody was diabetic does not necessarily mean you will be. You do things for preventive. And that's why primary care is so important, because it is preventive primary care, meaning we are trying to do things early so that we can prevent the diseases, so that you can live long and healthy and prosperous life. As Mr. Seabook said, instead of retiring and have all these bills and not being able to enjoy a retirement.
Next question. I think my brother Gary said, "Yeah, what's up, G?" He said, "Hey, Bill, I added a picture just now. Cool show, man. I'm checking in and participating and hope all is well." I appreciate you, G. Yo, my man, congratulations. I think you just retired, right? I think wifey put that out there. Then congratulations. Pearline just put this up there.
Yes. But see, you said 10, but you went from 1.0 because 10 was very high, but 7.8 for a diabetic, we want you at 7 or less. You're at 6.8. And so anything over 9, this is a A1C that's over 9, we start to worry that you're going to have end organ damage, and maybe you need insulin. And people hate to hear insulin, but maybe that's what you need. But I'm not surprised. That's why I wanted to know, Ms. Pearl, what it was, because 7.8 dropping it by 1.0 is very, very significant and very good. And I'm not surprised at those numbers. I was surprised when you said 10, because that's uncontrolled diabetes, and you don't appear to be that person. Oh, thank you. She wrote, "Love you, Dr. Mack." Okay. Oh, well, we'll talk about Ozempic.
Exactly.
Yeah,
So everybody, listen, it's 15 minutes after. The doctor is very busy. We appreciate her. I'm sure she could go on, but we don't want to extend. Let me tell you something. I tell people all the time in my life, I said, listen, people say, oh, you don't have to, when you go by to visit somebody, and they'll be like, oh, I said, I'm leaving. They say, oh, you don't have to leave yet. I said, no. I said, I'd rather leave and ask you for me to stay than me to leave, and you be like, I want him to go. You know what I'm saying? So I always appreciate you. Somebody asking me that. Let me tell you, you ever go to something? Hey, Doc, listen, you know, you ever have somebody at your house, they can just sit there, you be like, yeah, okay. You be like, oh, you're like, yo, you ready to go? Yo, what you got? What else you got to drink? You be like, oh my God, you know, you got any food to go? No, I want you to go. So what I do is I always leave before I'm asked to leave, and I always wait for somebody to ask me to come back. So you know what I'm saying? You know, it is what it is. So shout out to my man Gary. He just retired from transit. I appreciate you, brother. I'm glad you chiming in. I don't know if it's the first time or the last time. It won't be the last time. He said, thanks, man. Feels great to be free. He said, now we'll be a lot more time. Yes, please come by Row House and check out your brother, man. I appreciate you. Mark said, excellent show, excellent podcast. Thank you, man. So, sweetheart, with that being said and saying all of that, give us some positive affirmation, and then we're going to pass it to Doc. Say whatever you want to say. It is the holiday.
I want to say, don't get two puppies.
Oh, yeah. Not when you try to do a podcast. Exactly.
Excuse me for stepping away, but it's a lot of activity in the hall right now.
You see me in the background.
Yeah. They're very excited. But as always, Theresa, we truly appreciate your time, your advice, your love and care for all of us. We just appreciate it. It's no words.
Format you don't know, okay?
Yes.
Format that we should just keep perpetuating. It should go all over, because it's a very good one. And like you say, it's once a month. And if you needed something else, there's many doctors. We would all be willing to do it.
Well, listen, you're always welcome to come back. We got some slots that are open. I mean, right now we've condensed what we've done with Real Talk, just because I want to just put out some more positive affirmation, more clinical, just thought provocative stuff. I mean, like I said, I got the party aspect on Smash. I got that. But right now, people need knowledge of self. People just need knowledge, period. Yeah. So I think for those out here, let's listen, spread the word. For all those that are watching it on social media, Facebook, share it. You know what I'm saying? When are you going to sit down and have a conversation with a doctor for an hour and a half? And you got 2 for the price of 1 tonight. How about that? And then you just got 2 good-looking people. 3 good-looking people just to look at. How about that?
So it's been a while, but it's been good. being in the seat
absolutely.
next to you, Bill. And we're just a reminder for everybody: get yourself checked and don't be afraid to talk about it.
So give them some positive affirmation. What are you thankful for?
That was my positive affirmation.
You got anything you want to be thankful for?
I'm thankful for every single moment of every single day.
Absolutely.
For each of us. Period. That's it.
Doc, your positive affirmation and anything you thankful for?
I'm going to steal one from Dr. McKnight, who says, "Good health is wealth."
Yes.
Absolutely.
Oh yes. Oh yes. Great. Well, happy holidays.
Well, I didn't say my thing.
Oh, well, I have something to do.
No, we got something to do. I'm just going to say, listen, positivity is a beautiful thing. Keep the energy good. I'm also going to say, don't invite me by your house if you don't have any Tito's. Let me stop. Just talking.
Or
some sweet potato pie, or some hot sauce or something. I need some hot sauce. Listen, everybody, please. It's the seasons. Be careful. Watch your families. Watch your back. Watch your health. Love thy neighbor if he loves you back or she loves you back.
Mm-hmm.
We're in the different times. Doc, I don't put you on that political aspect. I don't ask you what your thoughts on the new attorney generals and health and stuff like that. I stay that with the other Dr. Quarter, but you're always free to give your chime in and stuff like that. But listen, please check yourself out. Check yourself. That's all I can say. Check yourself. Love the people that love you. Don't step out the box. Don't try to make somebody love you that don't want to love you. Don't do that. It doesn't make sense. That's it. So it's a beautiful world. We're out of here. Happy Thanksgiving to all. Happy holidays. Merry Christmas for those that are. If we won't see you Wednesday or any other podcast that we do between the time then and down. Right.
And one thing, I just saw Norman's last message. He said it's the season of depression. Take time to talk.
Yes.
So true for so many people.
Everybody, that's Dr. Theresa Mack. Thank you, Dr. James McKnight. That is Malika Foster, and I am Bill Foster. This is Real Talk Chronicles. Happy Thanksgiving.
You.
We'll be here Wednesday. I'll be talking about something. I'll be getting it in. Exactly. Good night, everybody.
Good night.
Thanks, Theresa.
Hey, my pleasure.
Absolutely.